Welcome back to Chapter 8, Lifting and Moving. In Part 1, we focused on body mechanics, proper lifting techniques, and how to protect ourselves from injury. Now in Part 2, we're shifting gears a little bit and getting more into the equipment and real-world application of patient movement. This is where things start to feel more EMS real life. You're going to see that lifting and moving isn't just about strength, but planning, communication, teamwork, and using the right tool for the right situation. Every move should have a purpose, and every movement should be controlled, and every decision should balance patient safety with provider safety. By the end of this section, you should feel confident identifying appropriate equipment and explaining when and why you would use each device. So let's dive in. This is what one-person vehicle extrication might look like in real life. In Image A, the rescuer reaches under the patient's arms and secures them from behind. Notice how the rescuer's body is supporting the patient's head and upper torso. In Image B, the patient is carefully lowered into a supine position once clear of the vehicle. Again, this isn't about perfection, but about speed with control. You're moving the patient out of immediate danger and then reassessing once you're in a safer location. Once a patient is out, reassess airway, reassess breathing, circulation, and then address spinal motion restriction properly. Emergency moves are really rare, but when you need them, we need them fast and decisive. Now we're moving into urgent moves. These are different than emergency moves. Emergency moves are about immediate scene danger. Urgent moves happen when the scene is safe, but the patient's condition demands rapid movement. We need to move the patient because staying in the same place delays critical care. Some examples might include an altered level of consciousness. Maybe they're declining neurologically and you need a better access to manage their airway. Inadequate ventilation, you can't effectively ventilate them where they're positioned. A patient in shock, maybe they need rapid transport, or extreme weather conditions, severe heat, cold, lighting, or environmental exposure. In these situations, we move the patient quickly, but we still attempt to protect the spine. This is not a drag. This is controlled rapid extrication. And rapid extrication requires a coordinated, knowledgeable team. This is not chaotic lifting. It's organized, practiced, and deliberate movement with one person directing the process. Urgent moves balance speed and spinal protection, fast but structured. Rapid extrication should only be used when a true emergency exists. This is not routine and this is not convenience. And it's not because it's easier. It's because the patient's condition demands immediate movement. The goal is to move the patient within a minute. That's fast, but it's still coordinated. Understand this clearly. Rapid extrication increases the risk of spinal movement. If the patient has a spinal injury, there is potential for further damage. So you must weigh risk versus benefit. If staying in the vehicle is staying in the vehicle more dangerous than moving? Is airway compromise worsening or is shock progressing? Always look at all the options before choosing an urgent move. Can you treat this patient in the place that they're in? Can you stabilize them first? Can you reposition without a full extrication? Good providers don't default to rapid extrication. They decide deliberately. Emergency moves are about scene danger, and urgent moves are about patient deterioration. Both require judgment and leadership and teamwork, and both should never be casual decisions. Okay, now we're in best case scenario. Non-urgent moves. These are used when both the scene and the patient are stable. This is generally what we're going to use. There's no fires or immediate threats and no airway compromise forcing us to make decisions quickly. This is where we slow down and we do it right. These are about planning. Before anyone lifts anything, the team leader should take a few seconds to think through the move. How many personnel do we need? Are there obstacles? What equipment are we using? Is there a clear path from here to the ambulance? You plan the procedure and the path, and you assign positions, and you give commands. Non-urgent moves are controlled, deliberate, and coordinated. And this is where proper body mechanics matter most. Because when things aren't chaotic, there's no excuse for sloppy movements. When the scene is stable and the patient is stable, we choose the most appropriate controlled move. One option is a direct ground lift. This is used for patients who do not have a suspected spinal injury and are laying on the ground. It's also appropriate when the patient needs to be carried over some distance, for example, from inside the home to the stretcher. In a direct ground lift, EMTs stand side by side along the patient. You coordinate the lift together and rise using proper body mechanics. Your legs doing the work, your back straight, and the weight close to the body. This is not a solo move, it's a coordinated, command-driven, controlled move. The key here is that we're not rushing. We're choosing this method because it's safe, efficient, and appropriate for the patient's condition. Choose the method that makes sense for the situation in which you're in. Another option for non-urgent moves is an extremity lift. This is used for patients with no suspected spinal injury who are either lying supine or sitting. It's especially helpful when the patient is in a small or tight space, like a cramped bedroom or a narrow hallway, when you can't position multiple providers side by side. In an extremity lift, one EMT positions at the patient's head and upper torso, and the other at the patient's feet. The EMT at the head typically supports the patient under the arms, controlling the upper body. The EMT at the feet support the knees and the lower legs. Just like every other move we've discussed, you must coordinate this verbally. You don't just lift when you feel like it. We lift on command. Again, this is only appropriate when there's no spinal concern. If there's any suspicion of a spinal injury, this isn't the move we're choosing. Choose the method that protects both the patient and you. Finally, let's talk about transfer moves. These are controlled moves used to transfer a patient from one surface to another, typically from a bed to a stretcher. The first option is the direct carry. This is used to move a supine patient from a bed to the stretcher when there's no suspected spinal injury. Providers position themselves along the patient, coordinate the lift, and move together smoothly from one surface to the next. The second option, the draw sheet method. This is often safer and requires less strain. Instead of lifting the patient directly, use a sheet or blanket under the patient to slide them from the bed to the stretcher. Less lifting and more sliding is better for your back. And then there's the scoop stretcher. I love a scoop stretcher. This device separates into two halves, slides under the patient, and reconnects, allowing you to lift with minimal movement. This can be helpful when spinal motion restriction is needed and you want to limit rolling. Again, this is about planning and control. Now let's talk about geriatric patients. The reality is most patients we transport in EMS are older adults. So this isn't a special population you'll see occasionally. This is our everyday patients. Aging brings physiologic changes that directly affect how we move and handle patients. Skeletal changes often mean brittle bones. Osteoporosis increased risk of fracture. Spinal curvatures like kyphosis change alignment. Joints are more rigid, and the skin is thinner and tears easily. This means the same lift that you'd perform on a 25-year-old can cause serious injury from an 85-year-old. Even small movements can result in fractures or pain. So your approach needs to be slower, more deliberate, more padded, and more supported. And just as important as the physical considerations are the emotional component. Many geriatric patients are scared. They might be confused, they might have hearing loss, then they may feel embarrassed about needing our help. So our tone matters. A calm voice, eye contact, and reassurance. Compassion is not optional in our patients. It's part of their treatment plan. Let's take a look at these images. This is a classic example of kyphosis, the forward curvature of the spine that often develops in older adults. Notice how the spine is not straight. The shoulders are rounded forward, and the head is positioned more anteriorly. This changes everything about how we might move this patient. If you try and force this patient to lie flat against a backboard without padding, you are going to cause them significant pain or even injury. Neutral alignment for this patient doesn't look like neutral alignment for a younger adult. You may need to pad behind the head and the shoulders. You may need to accommodate for natural curvature instead of trying to correct it. Older adults also have thinner skin, less muscle mass to cushion pressure, and higher risk for fractures from minimal forces. Even aggressive strap tightening can cause injury. Remember, gentle is strong in geriatrics. Your goal is safe transport without creating new injuries. Bariatrics refers to the management of obesity. In EMS, this is especially important in the context of lifting and moving patients safely. Currently, about 76 million adults in the U.S. are considered obese. That's 30 to 40% of the adult population. In addition, approximately 17% of children are obese. What this means for us is that this isn't a rarity. We will routinely care for and move patients that fall in this category. And because of that, we have to think about safety, not just for the patient, but for ourselves. Back injuries are the largest number of missed days of work. In EMS, improper lifting and moving techniques are a major contributor to this. So as we continue through this chapter, keep in mind planning, proper body mechanics, and using adequate help are essential when moving bariatric patients. Stretchers and ambulance equipment manufacturers are producing equipment with higher weight capacities to meet the needs of bariatric patients. However, increasing the weight capacity of equipment does not eliminate the danger to providers using that equipment. Just because a stretcher can hold more weight does not mean it's safer to lift without proper planning, manpower, and mechanics. Mechanical ambulance lift systems that we talked about earlier significantly reduce this strain on us, but are still uncommon in lots of areas in the U.S. And even some of our ambulances in our system do not have these mechanical lifts. So in many systems, safe lifting still relies heavily on teamwork, proper technique, and calling for additional help. This slide shows an example of an additional patient moving equipment, specifically a bariatric stretcher. These are specialized for overweight or obese patients and are designed with a higher weight capacity than a standard stretcher. You also notice that they have a wider wheelbase. That wider base increases stability and helps reduce the risk of tipping during movement. While these stretchers improve safety and stability for the patient, they're often heavier and bulkier, which means we still need proper technique and adequate personnel when moving them. Standardized equipment helps, but it does not replace safe lifting and teamwork. The pneumatic and electronic powered wheeled stretchers. These stretchers use power systems to raise and lower the patient, rather than relying entirely on manual lifting. The goal of this equipment is to limit the risk of injury to both providers and patients. By reducing the amount of force required to lift and load the stretcher, these systems significantly decrease strain on our back and shoulders. However, even with powered stretchers, proper technique, clear communication, adequate personnel are still essential. Technology can reduce risk, but not eliminate it. This slide shows a portable or folding stretcher. These stretchers are typically made of a strong rectangular tubular metal frame with durable fabric stretched across it. They're lightweight and easy to carry, which make them useful in areas that are difficult to reach, tight spaces, narrow hallways, or locations where your wheeled stretcher just can't be brought directly to the patient. Because they require full manual lifting, proper body mechanics, and adequate personnel are especially important when you're using these. This slide shows a Reeves stretcher. Flexible stretchers are excellent for storage and carrying because they can be rolled or folded, making them easy to deploy in tight environments. They're designed to conform around the patient's sides, which helps secure the patient during movement. These are especially useful in confined spaces, those near stairwells and small rooms, or even in a technical rescue operation shown here. Because they require manual lifting and carrying, coordinated teamwork and proper body mechanics are critical when using these. This slide shows a short backboard with a KED, or Kendrick extrication device, which is a vest-type immobilization device. Short backboards are used to help immobilize seated patients, specifically during vehicle extrication. The KED wraps around the patient's torso and helps stabilize the spine before moving them onto a long backboard or stretcher. While these devices have mostly fallen out of routine practice in many EMS systems, including ours, they're still carried on many apparatus. And there are still situations where they can be useful, particularly in controlled extrications where movement needs to be minimalized. As with any immobilization device, proper application and teamwork are still essential. Vacuum mattresses are an alternative to traditional backboards, particularly for immobilizing geriatric and pediatric patients. Air is removed from the device after the patient is positioned on it, which allows the mattress to mold around the patient's body and then become rigid. This provides effective immobilization while also improving comfort compared to a hard backboard. An added benefit of these is thermal insulation, which can help reduce heat loss, especially important in our trauma patients. This slide shows a basket stretcher, also called a Stokes basket. This is a rigid stretcher designed for patient removal in remote or difficult locations. Basket or scoop stretchers are commonly used in water rescues, wilderness rescues, rope rescue situations because they allow the patient to be fully secured and safely lifted or lowered. They provide excellent stability and protection during movement across uneven terrain. And here in our county, these are carried on fire apparatus and are frequently used for off-road or challenging extrications. Because they are rigid and require multiple providers at once, clear communication and coordinated lifting are essential when using these Stokes baskets. If a patient has a suspected spinal injury, they should first be secured to a backboard. The backboard is then placed inside the basket stretcher to allow for safe removal from the scene, especially in remote or uneven terrain. Once you return to the ambulance, the backboard can be lifted out of the scoop stretcher and placed onto your wheeled stretcher for transport. This allows for spinal motion restriction during extrication while still using the basket stretcher for safe removal. The scoop stretcher splits into 2 or sometimes 4 pieces. These pieces are placed on either side of the patient who's lying on a flat surface and then reconnected underneath the patient. Because of that design, both sides of the patient must be accessible. Once a scoop is secured together, the patient must be properly lifted and stabilized the patient must be properly stabilized and secured before lifting. This is actually one of my personal favorites for many situations, especially when we want to minimize movement while we're lifting someone from the ground. As always, proper securing and coordinating lifting are essential. Let's talk neonates for a second. Neonates cannot be safely transported directly on our wheeled stretchers. Oftentimes, they're transported in an isolette, which is designed to keep the neonate warm and protect the infant from noise, drafts, infection, and excessive handling during transport. The isolette may be secured to the wheeled stretcher or used as a freestanding unit, depending on the system. These units are often very heavy and typically carried on specialized critical care transport units and some helicopters, rather than our standard ground ambulances. Because of their size and weight, moving and securing an isolette requires additional training, planning, and coordination. We've already touched on this a good bit in class, but this is a good reminder. Equipment should be decontaminated after use for several reasons. Our safety, the safety of our crew, the safety of your next patient, and prevention of the spread of diseases. Anything that comes in contact with a patient, the stretcher, the straps, stair chairs, scoop stretchers, etc., should be cleaned properly according to your agency's protocol. Decontamination is not optional. It's part of safe patient care and provider protection. Proper positioning depends on the patient's chief complaint. For example, a patient reporting chest pain or respiratory distress should be placed in a position of comfort, typically a Fowler's or semi-Fowler's position. This helps with ease of breathing and reduces strain on the chest. On the other hand, however, patients in shock might be placed supine to help support circulation. Position is a simple intervention, but it can significantly impact patient comfort and physiological stability. Positioning really does depend, though, on what's going on with your patient. In late stages of pregnancy, patients should be positioned and transported on their left side. This helps relieve pressure on the inferior vena cava and improve circulation back to the heart. We'll revisit this later in class. If you have an unresponsive patient with no suspected spinal injury, they should be placed in the recovery position. This helps protect their airway and reduce the risk of aspiration. For patients who are nauseated or actively vomiting, we're going to transport them in the position of comfort, which is usually upright or lying on their side. Again, to protect their airway while keeping them comfortable. When we talk about medical restraints, the first thing to remember is to slow down and think. If a patient is combative, we need to evaluate for correctable causes first. Things like head injury, hypoxia, and hypoglycemia can cause altered behavior. If we don't identify and treat those, we're just restraining a symptom instead of addressing a problem. Always, always, always follow your local protocols. Restraining a patient is a serious intervention and should never be done casually. It also requires proper manpower. So the key points here: look for reversible causes, use enough help, follow protocol, and position your patient safely. When restraints are necessary, they need to be applied correctly and safely. A restraint should be applied to each extremity. This helps distribute control evenly and reduces the risk of injury to the patient or crew. After restraints are applied, reassess the patient, check ABCs, evaluate mental status, and assess distal circulation, including pulses, motor function, and sensation, to make sure the restraints are not impairing blood flow. And finally, documentation is huge here. Document why the restraints were needed, what alternatives were attempted, how were they applied, any reassessments performed, and the patient's response. Restraints are a medical intervention, and they require the same level of assessment and documentation as any other treatment. In our particular system and protocols, this is not something that you're going to be doing. This is something that would be done in the situation with law enforcement and potentially ALS involvement. Before you move any patients, you should take a second and think. Ask yourself, am I physically strong enough to lift or move this patient safely? That's not ego, that's a risk assessment. Is there adequate room to get into a proper lifting stance? If you can't position your body correctly, you're already at a disadvantage. And do we have adequate personnel, or do we need additional personnel? Calling for help early is always better than getting halfway through a lift and realizing we may have underestimated this. At the end of the day, injured EMTs cannot help anyone. Protecting yourself is a part of patient care. So as we wrap up this chapter, remember, lifting and moving patients is not just about strength. It's about planning, positioning, communication, and safety. We talked about bariatric considerations, specialized equipment, power stretchers, scoop stretchers, reeve stretchers, Stokes baskets, vacuum mattresses, and even neonatal isolettes. Each piece of equipment has a purpose, and knowing when and how to use it makes you a safer, more effective provider. We also covered patient positioning, medical restraints, decon, and personnel considerations. The common theme in all of this is protect the patient and protect yourself. Use proper body mechanics, call for help early, always follow your protocols, reassess after interventions, and always think before you lift. Your career longevity depends on the habits that you build now.